In this video, we will discuss the evidence-based practice movement and how it relates to manualized therapy. So back in the 1950s to 1970s, psychologists began to take a more critical look at psychotherapy. So up until this point, we talked in the last week about how psychotherapy really blossomed after World War II. So people are delivering psychotherapy, but it hasn't necessarily been researched to the extent that it has today. And so this is when the first treatment studies started to arise. And so the first treatment studies were simply asking, does therapy work? So you might take some therapists, ask them to deliver therapy to their patients, compare them to a group of people who aren't receiving therapy, and just see, are the people who received some therapy better off than the people who didn't? But this kind of has its limits. And at some point, people wanted to ask more interesting questions, such as which types of therapy work best, or which types of therapy work best for which disorders. And so in order to understand which types of therapy is being delivered, the best way to set up a study this way, you need to have therapists that are all delivering the same type of therapy so that you can then compare it to therapists who are delivering a different type of therapy. And so this is how the first treatment manuals were developed, was for this purpose, was for these treatment studies. And so a treatment manual is essentially a highly descriptive instruction manual for how to deliver a certain type of psychotherapy. So it might include like a week by week, like what to do in each session. It might include handouts and worksheets to use with the clients. It might just kind of review, like, here are the main points you need to cover when you're talking about this particular topic. So I've posted an example treatment manual on Perusal, and you certainly don't need to study it or know it. It's more just for your knowledge, just as an example, because I think it's really helpful to look at. And so as more treatment studies came about, certain psychotherapies kind of started to appear to be more effective than others. And so then the field started to ask, how can we designate which treatments work and how do we encourage the use of these treatments? And so this is really where the evidence-based practice movement came from. So you may have heard of some previous terms, or empirically validated treatments or empirically supported treatments, but the current phrase is evidence-based practice. It's often abbreviated to EBP. And evidence-based practice includes three components. So you have this three-legged stool. It is best defined as the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. So in this definition, it's incorporating research from treatment studies along with the clinical expertise of the clinician and the patient's characteristics. And so thinking about this overall movement and how manualized therapy fits in, we can talk about some of the advantages and disadvantages of using a therapy manual to deliver psychotherapy. So some of the advantages. First, it provides scientific legitimacy. So, clinical psychology or psychotherapy in general can encompass a lot of different strategies, some of which may or may not work. And by having a treatment manual that shows here are the detailed instructions for how to do this particular treatment that has been shown in a treatment study to work, it is providing scientific legitimacy to the things that we're choosing to do. It also establishes minimal levels of competence in our field. So it can be dangerous for somebody to call themselves a psychotherapist and just kind of do whatever they want. It may not help the client, it may even harm them. And so this is, in a way, saying, here is the therapies that work, and we expect this level of competence from clinicians. Related to this, manualized treatment has really improved training. So in graduate programs or other training contexts, or even for, seasoned psychotherapists who are learning a new skill, a manual helps them learn it in a very step-by-step way. That's tied to research and methods that work. And lastly, it really helps decrease reliance on clinical judgment. So clinical judgment is an important component of evidence-based practice. And I think people's personal experience seeing clients does give them certain skills that are hard to put into a manual. But an analogy I like to talk about is if you're going in for surgery, do you want your surgeon to be following the specific protocol with like safety checklists, doing the right incision at the right spot, following the exact instructions for surgeries that tend to go well? Or do you want them to go in and just kind of wing it based on how they're feeling that day? I'm guessing you probably want them to follow the kind of more checklist protocol model. And I think it's similar with psychotherapy. So we want to be delivering treatments that work to our clients, and manualized therapies help us stick to the protocol. In terms of disadvantages, some of the common critiques of manualized therapy are that it threatens the psychotherapeutic relationship. So if you take a look at the example, you can see that it might come off as kind of cold. It doesn't include a lot of like rapport building and, small talk and kind of empathy, those types of things that are, again, hard to put into a manual. And so some people argue that by using a manualized therapy, it's not allowing time for these things. However, I like to note that I think anyone who uses a manual in practice is going to be bringing in their clinical expertise to bring those, what we call common factors in, which we'll talk about in a future week. There are also diagnostic complications to a treatment manual. And part of this has to do with how treatment studies are conducted. So when a treatment study is designed, we want the therapist to be all delivering the same type of therapy from the manual. And we also want a patient population that is as homogeneous as possible. That is, they're all as similar to each other as possible. So in a treatment manual for depression, we're going to want to see if it works on patients with depression, but just depression. So the study may be ruling out people who have depression and anxiety or depression and post-traumatic stress. Whereas in the community, in practice, most people with depression are also going to have symptoms of other diagnostic categories. And so in this way, it can be argued that a disadvantage of manualized treatment is that it doesn't necessarily fit a typical person in the real world. A third disadvantage that has been posited is that it could potentially restrict practice. So if we are starting to write down what good therapy looks like, does that make it so that that is the only therapy that people can practice? And is that going to restrict, new developed therapies or the ability to integrate multiple types of therapy? So that is one argument that could be a potential disadvantage. A fourth one is that there may be debatable criteria for empirical evidence for certain types of therapy, and it might relate to how well they can be manualized. So, for example, behavioral therapy is very scientific in its nature. It's going to be a lot easier to write up in a step-by-step fashion compared to something like psychodynamic therapy, which is going to have a lot of more loose and kind of responding to what the client is bringing to the session. And that's going to be a lot harder to put into a manual. And so then people argue that just because something is difficult to study doesn't mean that it doesn't work. And so this is kind of an ongoing debate that we're going to talk about later in the class as well. Lastly, there are concerns about diversity and equity. And this ties to what I just said about the way that research studies are set up, where they want patients that all kind of look like each other. What that can result in is a history of having treatment studies that primarily recruit, white males with one diagnosis, in the attempt to have a very homogeneous patient sample. There are a lot of, follow-up research studies that are done to look at how treatments work in a more diverse sample in a real-world setting, but there are still concerns about a lot of these studies that maybe lack diversity and maybe recruit from certain communities and not others. And so with this issue, it's not necessarily an either or issue. It's not really an argument of should we accept everything that's an evidence-based practice and that's in a manual, or should we reject it? It's more about using it flexibly. And so I take us back to the three-legged stool, because I think it's really important to remember that clinical research is only one component. It's an important component, but it's equally important to clinical experience and patient preferences. And so I like this quote, as practitioners, we cannot manage without nomothetic and idiographic data. So what that means is group level data and individual level data. Findings based on both quantitative and qualitative methods, and a mixture of scientific and humanistic outlooks, which are psychology's dual heritage. And that's a theme we'll talk about ongoing in this class, is how, there are certain types of psychotherapies that come from a more scientific background, and there are others that come from a more humanistic background. And there are a lot of attempts to merge these. And I think that is something that is unique to psychology, and that makes it kind of an interesting field to do a research study in, because not everything is able to be operationalized in that way.